Hello, everyone. Welcome to another Nephrology VMR. Today, we have a very special member who's going to present an amazing case. Before I introduce him, Dr. Rich, would you like to give some words to our friends watching us?
Yeah, happy kidneys. I think March is Kidney Awareness Month, so this is definitely, very appropriate. I very much enjoyed the last session. I apologize for my babbling and tangential comments, but it's just who I am. But I enjoyed this, and hopefully we can have many more come. And it's great to be back.
That's awesome. I didn't know that it was kidney month. It is very ad hoc for
I
for
know, right?
the remembering how important it is. Happy kidneys. Our next case discussant is our dear Dr. Mengyu. She's part of the leadership. And Dr. Mengyu, would you like to say some words? Tell us what you're up to.
Yeah, I'm very excited to hear that this month is Kidney Month because our residents are actually doing board review focusing on nephrology this month. So I'm learning a little bit along with them. I'm a hospitalist, very excited and feel honored to be co-discussing with Dr. Rich today.
Back at you, man. You're back at you.
I, I feel under a rock right now because I didn't know it was kidney month. I'm so sorry. And now our case presenter, Jerome. Jerome, would you like to introduce yourself? Give us some words before we start with your case.
Yeah, absolutely. So my name is Jerome. I'm a third year medicine resident at the Medical University of South Carolina. I'll be chief resident next year, and
That's awesome.
I joined the academy in November. I'm excited to be a part of this space, to continue sharing cases, continue learning with everyone, and excited to present to Dr. Snyder and Mengyu today so we can get things started. Super excited.
Awesome. And then one more year and you'll be attending Dr. Jerome. That's the next step for us.
Absolutely.
Awesome. I think our scribe today is Susan or Julia. Would you like to share your screen and then we can start with the case?
All right. Let me just pull it up really quick. So for aliquot 1, the chief concerned, I was the admitting resident on the wards, and the ED gave us a call. There was a 61-year-old gentleman that came to the ED for an abnormal lab, and he was sent there by his primary care physician. Just a very brief one-liner. He presented to an urgent care earlier yesterday. He had a 4-day history of colicky, left flank pain. He had some dysuria that was pretty nonspecific, and he was essentially found to have a creatinine of 2.7. The last time that he had labs that we could see in our system was from a PCP visit 2 years ago, and his baseline creatinine was 1.1. And I'll stop there for aliquot 1.
So, Mengyu, we can alternate one who starts and then the other person. Let me start with the flank pain and then get your thoughts, and then with the next aliquot, you go first and I'll go second. And I think that way we tag team it. What do you think?
Sounds great. Yeah.
Right. So, just talking about left flank pain and acute kidney injury. So this is a 61-year-old gentleman, and this is not an uncommon reason why someone would be going to the emergency room. I've sent patients to myself to the emergency room with worsening. So, let's talk about common things happening commonly. So obviously this is acute kidney injury, or I'm going to make the assumption that there's an acute kidney aspect to this acute kidney injury. Certainly there could be underlying progression of a chronic component, but I don't have that information and would need more information. But making the assumption we're dealing with an acute process. So acute kidney injury and left flank pain. So whenever I think about renal dysfunction or acute kidney injury, I still go through the lens of pre-renal, renal, and post-renal. So let's talk about that in the lens of left flank pain. So post-renal, certainly first thing I would think about is nephrolithiasis. Is there a large kidney stone that is not able to be passed? Certainly, you could have other symptoms, including dysuria. I would expect to have some hematuria. Certainly, again, a stone usually can pass spontaneously 5 millimeters or less. As it gets to be above that, up to 10 millimeters, it becomes more difficult to pass spontaneously. Certainly, something else that could present with left flank pain could be left-sided hydronephrosis, either due to nephrolithiasis causing something like, for example, a UVJ obstruction or UPJ obstruction, or just hydronephrosis in and of itself for another reason. There could be, a mass, something encasing, something blocking. So something blocking urinary flow from a post-renal nephrolithiasis, left-sided hydronephrosis. Other causes of, let's say, intrinsic cause of left flank pain, left renal infarct. Again, that's usually not as common, but it's something that you think about with left flank pain. Usually there's a history of atrial fibrillation or a thromboembolic phenomenon. Patients will often present with gross hematuria with that, or they'll have microscopic hematuria. And often, if it's significant enough to cause left flank pain, they'll have renal damage and have increased LDH. Other things that could do it, nutcracker syndrome, where you have increased left renal venous pressure, renal vein thrombosis. So usually it's more bilateral, could certainly affect on the left side, but then I'd want to know the history of, there's like proteinuria, usually associated with like membranous nephropathy. But I've had a few patients over the years present with acute left flank pain, and that was the initial presentation for membranous nephropathy with left renal vein thrombosis. Something else that you always would think about, certainly with dysuria, is there an ascending complicated UTI like a left-sided pyelonephritis? However, usually in men, that's less of, usually you see that more in women than in men. So if you do see a left-sided pyelonephritis or that in a man, you would want to know more about their anatomy. And certainly would want to get imaging. I'd want to know if there's prostatitis, if he's had urinary symptoms. And I'd want to know if there's a prior history of dysuria, any BPH, neurogenic bladder, diabetes, something like that. There's other things but I think those are your, more common differentials that I think, we would start with.
Yeah, that sounds amazing. I think I would totally agree, using the pre-post intrinsic renal framework to approach the AKI. And I was also thinking expand a little bit on the flank pain, because I think automatically we zoom on the kidney, but also thinking of briefly just crossing my mind, like to make sure it's not an extrarenal cause, especially like anatomically, another chemist diagnosis like aortic dissection or acute aortic syndrome in the abdomen, like a AAA rupture or something, which could, potentially cause the AKI. So, especially in an elderly, especially if he has smoking history in the past. I think that's something just to cross my mind. Otherwise, flank pain, like there are some superficial causes that are not going to explain the AKI. So I think really that left us zooming on the kidney. I think kidney kind of besides what you said, I think post-renal is the first thing that came to mind, but also thinking about renal vasculature problem. I think last time there was discussion about renal vein thrombosis, could potentially complicating a more chronic nephrotic syndrome process, although we didn't hear about any sign of nephrotic syndrome yet, but also renal artery thrombus, like a renal infarct, could cause acute renal pain and clot. And especially if this patient's blood pressure is super high, then that would be more concerning. So I think we have a pretty good differential. I think imaging will really help us make progress and more clarification on the urine. Yeah, I think I'll pause here.
The one other thing just to add, I was just thinking about this just from a recent case, any type, we don't know if there's any trauma. And certainly trauma to the kidney, you can develop a subcapsular or perirenal hematoma. You get distension of the fascia. That can also be a cause of pain. And if the blood pressure goes up, you can get like a Page kidney phenomenon. So, So yeah, good stuff. I think we're ready for the next aliquot.
Let's do it. So briefly, whenever he visited urgent care, he reported being in his usual state of health, but then he developed sudden onset left flank pain that came in 15 to 20-minute intervals. He had a prior history of gout, and he said that level of pain was comparable to whenever he's had gout flares in the past, whenever he had dietary indiscretion. So he started taking 2 to 3 packs of goody powder per day. And for those of you not familiar, goody powder has essentially 325 milligrams of Tylenol, 500 milligrams of aspirin in each pack. And he would pick these up from his local gas station to temporize the pain. They discharged him with the steroid dose pack. They gave him some Flexeril, just thinking that this was MSK in origin, just given that it was an acute onset. And they got labs drawn, and it essentially showed this abnormal creatinine, and he was directed to the emergency room. So his brief emergency room course before they called for a medicine admission. On review of systems, he denied any fever. He denied chills. He denied any gross hematuria. There was no purulent drainage from his penis. There was no new sexual contacts. And he also endorsed urinary frequency. He absorbed some discomfort with his urination, but it didn't coincide with the start of these symptoms. He's had dysuria for about the past year or so. And just to advance the case, the ED got a CT abdomen pelvis without contrast. There was negative stone analysis. There was no hydronephrosis, and there was no other relevant intra-abdominal findings on the CT. They also got a renal ultrasound. There was no evidence of obstructive uropathy on either side. No hydronephrosis either. And for you, Dr. Snyder, his height, he was 5 feet 8 inches tall. His right kidney was 11.8 centimeters. His left kidney was 12 centimeters. And then there was no nephrolithiasis that was seen. There was normal cortical thickness, and there was no mass as noted. There was no prostatomegaly, and there was a decompressed bladder. And so the ED gave him 1 liter of fluid, and they called us for admission. And that's the end of aliquot 2.
Okay, Mengyu, you go first and I'll follow. Go ahead.
Yeah, wow, that's amazing. Because essentially we ruled out the most plausible cause of post-renal cause, and then there's no sign, because at first when I hear about gout, I wonder if the patient could have a baseline hyperuric acid in his blood and causing like uric acid stone. But even though that could be radiolucent on imaging, the fact that the CT scan didn't show any stone, I think really ruled that out. And I think about the medication, I don't know how much it contributes to the presentation. I think the steroid, I think I might miss like how much steroid the patient is actually taking, but I don't associate Tylenol with kidney disease. I think aspirin, more often like I think about associate NSAIDs and some others with kidney disease. But I love to learn if there's any other connection that I'm not aware here.
Yeah. So no, good stuff. So if we talk about, he has a history of gout. So gout can affect the kidneys in a couple ways. As you mentioned, you can have like acute uric acid nephrolithiasis. You can also get a what they call chronic gouty nephropathy, which is more like a micro, small uric acid crystals, kind of more of a tubular interstitial phenomenon, chronic gouty nephropathy over time. But you would expect to see something like nephrocalcinosis or something like that on a CT. And again, as you noted, it's radiolucent, but there's nothing on CT. So there's no evidence of a uric acid stone. I still would want to know what a UA shows, but that's, how that would normally kind of affect that. And certainly, as we talked about last week, as someone with hypertension, if there is a history of hypertension or gout, you often want to know occupationally, do they have a history of lead nephropathy, or something like that. And again, I'm extrapolating, but now in terms of, I don't know how much aspirin or Tylenol he had. Tylenol can be associated with papillary necrosis. So acetaminophen, NSAID use, it was initially described in patients taking phenacetin, which is, it certainly predates me, but what can happen is, you actually can get pain from the acetaminophen with papillary necrosis. You can have acute and chronic, because what happens is you actually get sloughing of the endothelium from like the tubular interstitial phenomenon. Patients with papillary necrosis can present with microscopic or macroscopic hematuria. So I don't know if the pain occurred after he had taken the Tylenol or if it had occurred. I think it sounds like he had the pain, then he took the Tylenol to kind of deal with the pain. But certainly, if he was reporting, you could have microscopic hematuria, but usually when I've seen like analgesic nephropathy, it's more chronic, but you can have acute aspects of acute papillary necrosis. Usually it can be unilateral. That can also present with flank pain. It can be bilateral. And when you get sloughing of like the tubular interstitial phenomenon, you can get gross hematuria as a consequence of that. It's been described with aspirin. It's been described with acetaminophen. And you can get chronic papillary necrosis with long-term use of acetaminophen. Now, this patient also took aspirin, and of course, the one thing that I'm worried about is aspirin toxicity. I don't know what a salicylate level was. But certainly, again, the prototypical, I'd want to know vital signs. The prototypical things that they always talk about is, a gap metabolic acidosis with a respiratory alkalosis because it's an uncoupler of dinitrophenol. So you get stimulation in the respiratory center, and you get the gap metabolic acidosis and the respiratory alkalosis. I'd also want to know a salicylate level. And again, just other manifestations of things that I've seen. I'd want to know mental status because sometimes you can get like CNS glycopenia where you can get a normal serum glucose level. Again, this is with salicylate levels like greater than 100. I'd want to know if you're short of breath because you can get non-cardiogenic pulmonary edema. And those are, you get other unique manifestations. But if the steroid, I'd want to get a blood gas at least to see, but it's start with the salicylate level. And certainly if it's elevated, you would want to alkalinize the urine to increase the solubility of the salicylate. But I'd worry about salicylate toxicity. And also, he's taken acetaminophen. I'd want to get acetaminophen level and liver function tests and put the acetaminophen on the Rubac-Matthew nomogram and make sure we're not dealing with acetaminophen, the toxicity, because who knows what he took. I'm still now. The renal ultrasound tells you a lot. The kidneys are both the same size, a normal size for this gentleman, and longitudinal diameter. Usually, the difference between one kidney and the other is about 0.5 centimeters, which is operator dependent. There's no hydronephrosis. There's no more cortical thickness, which means there's no echogenicity, which makes chronic kidney disease less likely and more likely that we're dealing with an acute process causing AKI and causing left flank pain. So in terms of things, and I'll just finish up with this sentence. In terms of left flank pain, I know what it's not. It doesn't look like there's any hydronephrosis. It doesn't look like there's any kidney stone. I'm still left with, could this be an aspect of papillary necrosis? Could this be, but I would want to know a UA. The other thing that I would also want to know is, he's had dysuria for a year. I wouldn't talk more about that. He said urinary frequency. Does that mean nocturia? Is he having burning when he urinates? Is he having, it did say that there's no prostatomegaly, but I'd want to know why he's having these urinary symptoms for a year, because as a male, that's not common. And that requires more of a further workup. So if he is having a history of UTI, I'd want to know why. I'd want to know bladder emptying. I'd want to know if he'd seen a urologist and kind of go from there. All right. I think I've babbled enough. All right. Thank you.
I think that's amazing. I wasn't aware. I think maybe remotely, I think acetaminophen and the relationship between acetaminophen and papillary necrosis, I think is something I think probably a knowledge gap of mine that I need a refresh. So thank you so much for the teaching.
No, I had a case of that. That's how I knew. And when a person came in, they would just have like intermittent hematuria and they would have pain, and the pain was bilateral, and that ended up being the diagnosis when we did an exhaustive workup looking for everything else, when we finally went back and was reviewing the medication that the patient had taken. I'm sorry, go ahead.
All right. And just to clarify a few things, so he never visited a urologist due to his year-long intermittent history of dysuria. And he hasn't had any PCP follow-up since those last set of labs. So he's essentially been lost to follow-up for this time. So on to just some of his past medical history. He did have hypertension. He was not controlled on HCTZ. He had a history of gout. He was intermittently compliant with allopurinol. He has obesity and he did have prediabetes. He was on a GLP-1 injection, but he switched to the PO form of semaglutide 3 months ago. Unclear how he was getting this if he wasn't having consistent follow-up, but he's never been a diabetic, and he has never been on any subcutaneous insulin. He had sleep apnea, and he was compliant with his CPAP machine. And he did have this relevant past medical history of chronic low back pain from a car accident 5 years ago. And he's been taking ibuprofen 600 to 800 daily for the past 4 years. So as far as the medicines, I've already talked about a little bit. So allopurinol, aspirin, 81, HCTZ, lisinopril. He was on Crestor for hyperlipidemia, and then he was taking Miralax, PRN for constipation. He also had colchicine as needed, Celebrex as needed, Flexeril as needed for the back pain that he got from urgent care. And then he was taking the ibuprofen daily, as I already said. For his occupation, he was a commercial long-distance truck driver. He's been doing that for the past 30 years. And by way of health-related behaviors, he had 1 standard drink of alcohol per night, 2 to 3 drinks on the weekend, no history of tobacco use, and no history of illicit drug use or any recreational drug use. And that'll be aliquot 3.
I guess I'll go first this time. So, just looking at his meds, and again, with nephrology, you're always looking at medications and looking for potential interactions. So just, talking about he had been taking intermittent ibuprofen with this, so certainly there is a phenomenon, if we talk about that in lisinopril, called vasomotor nephropathy. And that is in someone who has decreased effective arterial blood volume, or if the kidney is outside the limits of autoregulation, which is usually less than 80 millimeters of mercury or above 180. And that's where you talk about to maximize your renal perfusion, or to you see changes in your afferent or efferent arterial in terms of regulating interglomerular pressure. So in a setting of, I'm going to make the assumption of this person who's presenting with left flank pain, and having these urinary symptoms. I'm not sure if he's had decreased oral intake or any nausea or vomiting, with that pain, but certainly you can induce that some in terms of the AKI. You may have an additional medication effect, and this is almost an encyclopedia of what not to take in terms of what can cause AKI. So lisinopril dilates the efferent arterial, lowers interglomerular pressure, and in a setting of a person coming with acute events, certainly can cause like a vasomotor nephropathy, and can increase creatinine levels, or depending on if the insult is significant, can develop an ATN. NSAIDs, certainly, again, prostaglandins or vasodilators needed for renal perfusion, and NSAIDs, in combination with lisinopril, especially this person taking Celebrex and ibuprofen, certainly the risk of AKI from a hemodynamic point of view is going to be significant. And that's going to be the most common what you're going to see. NSAIDs in and of themselves can also be associated with minimal change disease. But it's a special kind of minimal change disease because it's associated with interstitial nephritis. But usually it's more prolonged, where they've been on the NSAID for a few months. They'll have minimal change disease, they'll have pyuria, and that's a distinct entity with NSAIDs in and of itself. NSAIDs can also cause membranous nephropathy. Allopurinol is an interesting medicine. So one of the things about allopurinol is if the person is of Asian descent, there's actually an HLA haplotype that they need to that needs to be checked. I always have to look up the 2 different HLA haplotypes to determine if they can actually even take the medication because of the risk of side effect from that medication. That's a board question in IM they like to ask in rheumatology with regards to allopurinol. Allopurinol in some patients can cause like a hypersensitivity reaction. You can get acute interstitial nephritis. So that's one of the things with that medication. One of the things about colchicine, colchicine is metabolized by CYP3A4 enzyme. So anything that can interact with that, it can increase his risk. It doesn't look like he has that interaction. If the patient was on Lipitor, I'd worry about a Lipitor colchicine interaction because they're both metabolized by CYP3A4. Crestor is not, so you're not going to get that interaction. But colchicine, you can get myopathy, you can get diarrhea. So again, and certainly semaglutide with nausea, vomiting, oral intake, that can, so there may be a hemodynamic effect here with the AKI. And again, I'd want to know acetaminophen level. I'd want to know salicylate level, and kind of going from there. I think I'm going to keep this aliquot talking about the medications. Go ahead, Mengyu.
Yeah, I love your analysis. I definitely was also called attention by the NSAIDs, both COX-2 inhibitor, the Celebrex or celecoxib, and the ibuprofens. I associate that with AIN or CTI, so acute interstitial nephritis or chronic tubular interstitial nephritis. And I think classically for the AI, because this patient presents acutely, I was thinking like if it's acute, then usually that happens like 6 to 12 months after exposure of this medication. And patient, I think classically have fever, rash, eosinophilia, but I actually am curious how the chronicity about this patient's kidney dysfunction, because the last check was 2 years ago, and And depending on how long he has been taking this medication, maybe he's already brewing some more chronic form of interstitial nephritis. And then this acute form could be acute complication, which I think papillary necrosis is something I have to read more about, kind of refresh my mind, something I've mostly learned, back in preparing for the step exams, but haven't really encountered too much in real reality. But I think that could potentially be the acute component, or as Rich mentioned, complicated by MN or MCD, then developed some. But again, I don't see edema or nephrotic syndrome, so I think maybe that's less likely at this time. But yeah, I think those two are what came to mind. I think the urine analysis will be super helpful, whether it will show I think asking patient if he has any chronic polyuria, nocturia, which could suggest a more chronic component, and check the urine for the degree of pyuria. Sometimes there could be hematuria with tubular interstitial diseases, and then any acid-base disturbance, and then the degree of proteinuria. And I didn't mention earlier, the CAS, if there's WBC CAS, that could also be more suggestive of an interstitial nephritis kind of thing.
Yeah, I mean, with the ultrasound being normal, certainly if there was a chronic component, you would at least make the assumption you would see more echogenicity. So making the assumption that we still can't rule out that there's not a subacute chronic component that yet hasn't shown echogenic kidney changes, but it's still up in the air right now how much of this is an acute component versus progression of underlying chronic kidney disease. And certainly he has a reason. If he's had uncontrolled hypertension over the past few years, if a person on these medications, they may also have prior bouts of ATN, which may have not been caught, and that can be a risk factor for, chronic kidney disease. And, after the physical exam on the next aliquot, I'm going to come back and talk more about the left flank pain. All right. No, great stuff. Thank you so much. All right. I think we're ready for the next aliquot.
All right. So for aliquot 4, for his vital signs, he was afebrile. His blood pressure was 165/97. His heart rate was 87. And he was on room air, sitting at 95%. His BMI was 44, and he is African-American male. On exam, generally he was well appearing, no acute distress. His head and neck exam, he had some periorbital edema, and there was also some circumferential darkness to his skin around both eyes, both orbits. And there was extraocular movements were intact. Cranial nerve exam was unremarkable. His vision was actually stable, and no changes over the past few months either. Cardiopulmonary exam, there was no JVD, but it was difficult to assess in the setting of his habitus with the BMI of 44. There was no noted murmurs, no crackles on lung exam. There was no wheezing on a bilateral basis, and then there was normal work of breathing. His abdomen, he had an obese abdomen. There was no CVA tenderness on the left side. There was no distension of his abdomen. There was no fluid wave. And then obviously trying to get an organomegaly exam was pretty difficult in the setting of habitus. He had pitting edema to the bilateral lower extremities up to the knees. And that'll be aliquot 4. And I'll get into some labs in the next aliquot.
Yeah, thank you, Jerome. I love this aliquot. When you mentioned that he's African American, like a Black person, and also having obesity, they both raise the possibility, or they're both major risk factors for FSGS. Although one more African Black population, I would more think about primary FSGS, which comes with more acute onset and profound nephrotic syndrome. But then obesity-associated FSGS is a form of secondary FSGS that I think could also be at play, especially with BMI of this degree. And so there's and then I think the exam revealed what we didn't know before was that peripheral edema to the knees, and also periorbital edema. I think both actually now we have clue for nephrotic syndrome. And I think as mentioned earlier, NSAIDs could be associated with MCD or MN, so those could be also related here. I think really knowing the underlying, I think getting renal urine protein quantification will be helpful to kind of help us clarify if there's nephrotic syndrome, and see if there's any hematuria to suggest any nephritic component at all. But although I'm kind of pondering about the circumferential dark area around both orbits, I'm curious. Yeah, I have to think more like how that plays into the picture. I'm curious, Rich, if you have any thoughts. And
My
again,
first,
coming
I'm
back to the left flank pain, I think now that we have nephrotic syndrome, I think that raises concern for renal vein thrombosis. Oh, but I think you said, but actually, I think Jerome, you mentioned there's kidney ultrasound. I can't remember if there's a vascular duplex that was studied. I think maybe we need that component to assess that part. But
Yep,
yeah,
there was no duplex that was done on the ED ultrasound, but more to come.
So, first question, was there any family history of any kidney disease?
There is family history of kidney disease. No one was on dialysis, but there were multiple people who were following with nephrology.
And do you know the age in which they were initially diagnosed?
Around their 40s.
Okay, so last week with Mark, he asked me about APOL1 and kidney disease. And again, usually, so APOL1 is a family is associated with FSGS, usually primary, and it's inherited and it can be seen in families. Usually, it's diagnosed earlier than the age of 60. Usually, you see it in their 20s or 30s. Although with the family history that you mentioned, Jerome, even though he's in his 60s, can't rule it out. Although usually it's more of a collapsing variant of FSGS, and patients are often on dialysis in their 20s and 30s. And there's a family history, and usually affecting younger African American males. The fact that on physical exam, and you pointed this out about periorbital edema, when you see that, that is at least for me a significant mark on physical exam that there's an aspect of hypoalbuminemia. And again, the physical exam, when we look at things like cardiopulmonary findings, I mean, our sensitivity of our physical exam is probably about 50% for things like JVD, cardiac murmur. And this is even in studies that were done with cardiology, in terms of you can get two cardiologists in the same room and get, a slightly different physical exam. So you're seeing more of point of care ultrasound, although, the exam is going to be difficult in someone with a BMI of 44. But but periorbital edema, I'm making the assumption that there's hypoalbuminemia. Again, there's no JVD. Again, at least on physical exam, there's no evidence of any heart failure. Their lungs seem to be clear. He does have bilateral pitting edema up to the knees, and that is, as you pointed out, in conjunction with periorbital edema, I'm going to make the assumption we're dealing with a renal process. Of course, it's also a renal VMR, so that kind of makes that easy. So, but I'm going to make the assumption that we're dealing with, as you pointed out, hypoalbuminemia and nephrotic syndrome, and I think there's enough with the physical exam to kind of make that leap. Now, on physical exam, this patient presents with flank pain, but there's no CVA tenderness. So at least that you had mentioned. So CVA tenderness, or what they call Lloyd sign, is pretty significant for something kidney related, whether it's a pyelonephritis, whether it's a hydronephrosis, whether it's there's also another one called chandelier sign, which was you tap on the back and the pain is so bad they want to jump up and grab the chandelier because they don't want to be touched anymore. That's an older sign, but so the question is, and also again with the increased BMI, the physical exam, even for costovertebral tenderness, may not be as sensitive as you would think. Now, in terms of, you had mentioned, and you were right on the money in terms of obesity, in terms of different forms of FSGS. So when we think about FSGS, and again, just anchoring on that, certainly it's higher in African Americans. You have, there's a new classification now. There's primary FSGS, there's secondary FSGS, there's a hereditary form of FSGS, and then they call FSGS non otherwise specified. And usually those are like, secondary FSGS, from a scarring, something happened, you get scarring of the kidney, any process that can scar the kidney can give you a secondary FSGS, as well. But when we talk about secondary FSGS, especially with obesity, one of the things about that is usually it's tubular range proteinuria. You're not going to expect nephrotic range proteinuria from a secondary FSGS process, although certainly he's at risk with hyperfiltration for that to occur. When usually it's like, less than 3 grams of proteinuria, and with weight loss and use of an ACE inhibitor, ARB, you can actually get improvement. And one way on exam to tell the difference between primary and secondary FSGS would be the presence of glomerulomegaly or high increased glomerular size in electron microscopy. And there's often an association with sleep apnea as well, and treating the sleep apnea also helps with the secondary FSGS perspective. So, but with the periorbital edema and, this, I'm going to make the assumption we're dealing with more of a primary process. And I'm going to, anchor, and certainly the different things that we talked about, he's at risk for. The scenario you gave Mengyu, and again, I want to wait till we get some of the labs back before I talk about that. But especially with the periorbital edema and the pitting edema, my concern is for more of a primary nephrotic syndrome, possible glomerular process. He is hypertensive. I can't rule out a nephritic or a nephrotic syndrome, although again, there's often overlap because even FSGS and things like that, you're going to see hematuria like 1/3 of the time microscopic. So, but certainly, with the flank pain and the connection between a membranous with renal vein thrombosis would be one of my differential diagnoses here. So that's, sorry for the babbling, but good stuff. All right, go ahead.
All right, so we'll proceed to some of the lab work. So the CBC white count was 7.7, neutrophilic predominance. Hemoglobin was 12 with the MCV of 75. His platelet count was 270,000. His complete metabolic panel, sodium was 137. His potassium was 4.6. His bicarbonate was 26. His BUN was 44. His creatinine was 2.4, and this was after he received 1 liter of fluid in the ED. And his liver enzymes, his total bilirubin was normal. Liver enzymes were normal. Alk Phos was normal at 41. His albumin was 2.6. His A1C was 5.3. And his BNP was 105. And then I can give you the urinalysis as well. His
that'd be good.
urine sediment was, specific gravity was 1.015. There was some small amount of urine blood that was noted. pH was 7. Nitrite and leukoesterase was negative. Microscopic analysis showed 3 to 5 white blood cells per high-powered field, which is abnormal. There was 3 to 5 red blood cells per high-power field, which is also abnormal. The CAST analysis was negative. There was no dysmorphic dysmorphic RBCs, no acanthocytes that were reported. And the urine protein to creatinine ratio after a 24-hour collection was 14 grams. The urine culture was eventually returned negative.
Okay.
All right.
Who's up first? Is it me or you this time, Mengyu? I can't remember.
I think it's Dr. You, Rich.
Okay. All right. So certainly this person has hypoalbuminemia. You're looking at the urine, and he does have a little bit of pyuria. Usually with something like interstitial nephritis would expect to be more. And again, a normal red blood cell is like 0 to 2. It's 3 to 5. Again, and that can be seen with different forms of nephrotic syndrome. So seeing microscopic hematuria, you can see that with like FSGS, minimal change. So that's not uncommon. So when we talk about, so I'm going to make the assumption here, he's got protein. He has 24-hour urine protein was 14 grams. So I just want to comment on something. And this is even going back to last week when we were talking about the case. There's 2 ways to check a quantify urine protein. One is a 24-hour urine protein, and the other one is a protein creatinine ratio. The reason, so when you look at many of the studies, if a person is within the bell curve, you can utilize a protein creatinine ratio first morning urine collection, and it is supposed to be as reliable as a 24-hour urine protein. And this is more in the outpatient, because the reason is when people do 24-hour urine proteins, they just pretty much do it the wrong way. I mean, we're not used. I mean, if you think about the containers in the fridge, you have to go to the fridge in order to, to avoid. People often forget, or they will either forget to fill it or fill it too much. So it's not really an accurate collection. We often do a 24-hour urine creatinine to ensure that we're getting an accurate urine collection. So someone who's a 60-year-old male, for example, should have about 15 to 20 milligrams per grams per kilogram in a 24-hour urine collection. So, and in someone with a BMI of 44, one can make the argument because he's outside that bell curve. So again, your creatinine, if someone has no muscle mass and you do a protein creatinine ratio, you're going to have a dramatically increased proteinuria, protein creatinine ratio, which may not reflect the true aspect of proteinuria. Same thing as someone is either very muscular or has a severely increased BMI. So doing a 24-hour urine protein here is often the right way to get the most accurate urine collection. So again, if they're within the bell curve, you can do a protein creatinine ratio. But if someone is outside of the BMI, has significantly decreased muscle mass, you will get an artifactually increased protein creatinine ratio. So that's an important thing. So this person certainly has nephrotic syndrome. He has 24-hour urine, again, more than 3.5 grams, has hypoalbuminemia, has edema. The only thing we don't have is a lipid profile, but I'm going to make the assumption that he's hyperlipidemic. So in this person who's 61, the question then is, what would be my differential? So your top 4 conditions that would cause idiopathic nephrotic syndrome. Again, we've ruled out diabetes. Again, he's got a hemoglobin A1C of 5. Hypertension causes more of tubular interstitial disease. Again, we talked about papillary necrosis, but I mean, usually you're seeing more with acetaminophen, but usually you're seeing more red cells in what you have here, and there's usually sloughing, and there would be more expected gross microscopic hematuria. So I think that's less likely here. So if we're talking about the nephrotic syndrome, let's talk about membranous. So could this be idiopathic membranous? Yeah. And could he have renal vein thrombosis with that? Yes, the left flank pain. What's different about the membranous is, usually when it presents, it's certainly, again, any nephrotic syndrome can do anything. It's usually, I'm not expecting this degree of proteinuria. Usually it's, I'm looking at 6 to 8 grams. It's not as aggressive. That being said, it can do anything, and one of my differentials would still be a membranous nephropathy with a renal vein thrombosis with the left flank pain. Although the flank pain could be a misnomer and could just be more musculoskeletal in nature because he's had low back pain. Could he have a form of a primary FSGS? Absolutely. I'd want to know more about his family history, although, again, I think the APOL1 is less of an aspect here because usually it's, again, associated with renal failure when they're younger. But could he have, I don't think he has a collapsing variant of FSGS because then he'd have really severe renal failure. Usually it's a lot worse. They're globally anosarchic. Could minimal change present like this? Absolutely. You can have minimal change. Usually it's more aggressive. Like we talked about, the patients are usually a little more, it doesn't look like he has anosarchic, although I think the fluid status is difficult to tell because of his increased BMI. But certainly, again, in an adult, you're looking for a reason. You're looking at medications that they may be on. NSAIDs could certainly cause minimal change disease. He's been on that, and that could present with the patient's presentation. You could also get AKI, and the NSAID may or may not may be playing a role with some degree of left flank pain. Certainly, he deserves a serologic workup. But I think, given the severity of how he's presenting, I still think you could have possibly NSAID minimal change, although you would expect to see more pyuria because it's usually associated with interstitial nephritis, and he only has 3 to 5 white cells per high power field. He does not have any serum eosinophils, but again, it's still in the differential for me. And certainly anyone who's in their 60s, you're thinking about amyloidosis, primary light chain, which would still be just given the age group. So I would be checking a serologic workup. I'd still be doing the SPEP, serum-free light chain. I would do a serologic workup on this gentleman, and then kind of see where things go and kind of go from there. He's likely going to need a kidney biopsy, although it's going to be very difficult to do in someone with a BMI of 44. And that's, so then the question is the kind of biopsy you're going to do. CT guided biopsy with a BMI of 44 is going to be difficult to visualize even under a CT. And sometimes they can do a transjugular biopsy. But then one of the issues is that you sometimes worry about not getting enough glomeruli and just getting more of medulla than compared to cortex. All right, I'll stop there for this one. Sorry, I babbled again.
Oh, that was wonderful. I don't think I have too much to add. I think practically speaking, at this point, since we coined it as nephrotic syndrome, I think we'll do all the workup. I think I love this case, Jerome, because I think the differential diagnosis is so rich because the patient has all the risk factors for every type of nephrotic syndrome, from
Yes, he does.
diabetic nephropathy to FSGS to MCD. I wonder the age is a little bit still younger for the MCD in older population, but that is also and membrane nephropathy if we think about thrombosis. So I think I'm gonna send, in addition to what Rich said, I think also send HIV, HBV, Hep C complements could help, like make sure it's not a MCGN or some other format of an anti-PLA2R. But yeah, I think, and getting the renal vein or renal duplex vascular ultrasound.
So the only thing I would just add is in someone with this size, your renal venous Doppler is not going to be as high yield because you're not, again, it's based on sound waves. So, anything that, the increased BMI is going to prevent you from the venous Doppler from really, in a situation like this, depending upon what studies come back, I would almost want to get an MRV to kind of look at the renal veins or, a dedicated, and I don't think that would be unreasonable here, especially with the continued flank pain with nephrotic syndrome. And remember that any cause of nephrotic syndrome can cause renal vein thrombosis. It's just been more highly seen in membranous. And again, the guys on NSAIDs, and NSAIDs can cause membranous nephropathy with renal vein thrombosis as well. So it's going to be very interesting how this turns out, because the guys on every medication, as you pointed out, Mengyu, which can cause everything. But certainly, membranous with NSAID with RVT. But to get a study, I would want to get something like an MRV, because I don't think a renal ultrasound, given this guy's size, is going to be enough to really visualize the veins.
Yeah, that's such a wonderful point, Rich. I totally agree. And also, like, I mean to circle back on the circumferential dark area around the orbits. At first the description made me think about hyperpigmentation. So I was like, what could that be? But I think as I think he mentioned in the chat, whether it's just part of the periorbital edema process, or is it like actually bleeding around the eye, which then would make me think of amyloidosis, as I think Salsa mentioned. But yeah, I would love to hear more. Gerald.
Yeah, absolutely. All right. So for imaging, very briefly, a chest X-ray, mildly enlarged cardiac silhouette, mild interstitial edema. His transthoracic echo, he had an ejection fraction of 60%, grade 1 diastolic dysfunction, normal valve study. Left atrium was mildly enlarged. There was some mild left ventricular hypertrophy that was circumferential. We did not have access to the MR just because of habitus was actually challenge for that as well. So he did end up getting a renal artery duplex ultrasound. Renal vein duplex was also negative. There was no arterial, no venous thrombosis that we could see. Obviously, not the ideal study just because of habitus as well. So some advanced serologic workup, complement levels were normal. HIV was negative. Hepatitis panel was negative. ANA was negative. ANCA serologies, MPO and PR3 were both negative. SPEP, he had a 0.8 grams per deciliter, which did not meet the threshold for monoclonality. Kappa and lambda ratio was abnormal at 2.33. The kappa ratio was 64.2 milligrams per liter, upper limit of normal being 19. And the lambda ratio was 27.5 milligrams per liter, upper limit of normal being 26. Anti-GBM antibodies were negative. All the other IgG, IgA, IgM, those were within normal limits. And then a serum phospholipase A2 receptor antibody was negative. And then I know Dr. Snyder, you talked about the salicylate, Tylenol, UDS, all those were negative. Sorry, Julie, I didn't send that over to you beforehand, but all those things were negative as well.
All right. I think,
Yeah.
are you going first? Go ahead, Mengyu.
I think so. Wow, this part, this aliquot is a bit more challenging because then we kind of have to zoom in on the what are the most likely diagnoses, but based on the lab we have. I think we ruled out certain possibilities, including the PLA2R being negative and the
Right back.
yeah, some secondary causes. I'm trying to think about the kappa lambda ratio. I'm trying to kind of find my notes and remind myself, like, because I think 2.33 is
Howdy.
a little elevated, but not that elevated. So uh, I'm trying to think if this, like the degree of elevation, is this something I might call lab or, to kind of discuss or kind of find more about whether this could be like a MGRS type of physiology here. My suspicions, no. I feel like in the end, what we need is a renal biopsy actually to see if there's any deposition of those, and then see if there's and assess for other causes like FSGS, as we mentioned earlier. And I think MCD also remains on the possibility, or secondary forms of MM. But although we don't, yeah. Yeah, what do you think, Rich?
Yeah, yeah. I just got a puppy, so I have to keep looking around to kind of find her. I had another cat dog who had just passed from liver cancer, so every time I'm looking around to see and he's getting into mischief. I can introduce you to everybody if once I can find him. So yeah, a normal, especially with chronic, with an abnormal creatinine, you can have a normal kappa lambda ratio anywhere from like 1.5 to 3.1. And the reason that and I always have to look up which one is a larger molecular weight, kappa or lambda, though they're both large molecular weight proteins. And the reason that they're elevated is because they're such larger molecular weight proteins, especially in the setting of acute kidney injury or chronic kidney disease, they're not as readily cleared by the kidneys. So they tend to stay around a little bit longer, especially because of the larger molecular weight. Usually if you were thinking about like a light chain process, you're really looking like, for a kappa lambda ratio that's going to be a lot higher. If you're thinking about like a monoclonal immunoglobulin deposition disease or different aspects of like MGRS. So with that creatinine of 2.4, I'm not that impressed by a kappa lambda ratio of 2.3. At least that's how I would interpret it. In terms of the other serologies, again, complements or normal hepatitis, I think in terms of, certainly I agree with you, we kind of need tissue. In terms of, where I'm thinking, certainly I think differentials would be like a membranous nephropathy, questionable NSAID induced with an interstitial nephritis component, although I'm not impressed by the pyuria. Usually with interstitial nephritis, you're going to see more pyuria, a little bit more hematuria, although he does have that. You can extrapolate. You don't always have to have serum eosinophils. Remember that the classic presentation for interstitial nephritis of fever, flank pain, and eosinophil, can present only 10% of the time. Most of the time, you're just seeing more pyuria. Urine eosinophils used to be to make the diagnosis, although it's not sensitive now. But certainly, given the flank pain with the presentation, an NSAID-induced minimal change disease with interstitial nephritis would still be one of my differential diagnoses. I can't rule out an NSAID-induced membranous or as a secondary with a renal vein thrombosis. That would be something else. Again, certainly given the age, amyloid would still be in my differential, although the fact that the kidney size is normal would argue against that. Usually the larger kidneys. And certainly FSGS would be last, but FSGS again, if they have severe nephrotic syndrome like this, can't rule out a renal vein thrombosis as well. Again, usually seen with membranous. I would want to know an LDH. Renal infarct is in the differential, although again you would expect to see more hematuria, but that's kind of like where I am. I'm curious to see what the kidney biopsy demonstrates, because there's probably something else that I'm completely missing. But I'd be curious to see what the biopsy shows. I'm just going to find my puppy so I can introduce everybody. Let me just find him. I'll be right back.
I'll wait till he comes back so we can get to the biopsy.
So this is Cody. I know,
Hi,
right?
Cody.
When I want to put him to sleep, you know what he falls asleep to? Renal podcasts. They are so it's like, like reading Brenner and Rector, is again nephrology I'm very interested in, but it's very very dry. But if I want him to fall asleep, I just put on like a renal podcast and he falls asleep very quickly. I'm sorry.
All right. So I'll give you the kidney biopsy results now. So there was 2+ amounts of granular deposits of IgG in a focal segmental pattern. There was 2+ amounts of C3 that was within those granular deposits. There was 3+ amounts of kappa light chains, and there were 3+ amounts of lambda light chains that are seen in a similar distribution. The PAL2R stain was negative on the biopsy, and the Congo stain was also negative on the biopsy. So we called the pathology office, and they also gave us some additional commentary. They said there's evidence of tubular injury within a background of disproportionately greater interstitial fibrosis compared to the degree of tubular atrophy. And there's global glomerulosclerosis within the limited biopsy sample. And the foot processes show severe effacement. And then I'll reveal the final diagnosis in his outpatient course after you all discuss.
So, you had mentioned, if you're talking about that there's a significant amount of, so any type of foot process effacement, you can see this with FSGS, you can see this with minimal change. It is often thought that minimal change and FSGS are part of the same process, but I mean, a primary FSGS, you will see foot process effacement. You can also see that with minimal change as well. If you're talking about a significant amount of interstitial fibrosis, certainly with nephrotic syndrome or things like that, over time, this could be a secondary FSGS, secondary to a scarring process, where you could have a primary FSGS or a minimal change, which has scarred over time. And to give you, this may have been more of an insidious, more chronic process than we thought. Phospholipase A2 negative receptor being negative, again, argues against primary membranous. Congo red stain being negative argues against amyloidosis. But given the fact that there's more of a tubular interstitial fibrosis, I think there's been more of a chronic process, maybe a primary FSGS or primary minimal change that has turned into a secondary FSGS over time, especially with whatever's here, I do not think is reversible. So I don't think there's anything readily here that would be treatable. And the problem is sometimes when you have that degree of scarring where things are so sclerosed, it's hard to tell what the initial process was. So sometimes you really want the electron microscopy results to give you a sense of what could possibly be the initial process. But usually when, if you're talking about severe effacement, I'm thinking, you're going to see that. You won't see that with secondary FSGS. So I'm thinking a primary FSGS or a primary minimal change may be induced by NSAID that's been going on for a while, which has now caused a secondary FSGS and secondary scarring and tubular interstitial fibrosis. I'm curious as to what this shows.
Yeah, I'm glad, Rich, you took this aliquot, but I was trying to pull my remote memory from my experience in medical school reviewing kidney pathologies as part of my research project. But I feel like IgG and C3, they happen a lot in membranous nephropathy and granular deposits. It makes you think about maybe some electron dense, that's where the deposits are happening. Usually subepithelial for membranous nephropathy. I'm trying to remember, I'm trying to think for membranous, for MCD, is it usually just foot process effacement without too much deposits in the staining, eye staining? And then also for FSGS, I think I need to read more, but I wonder if those also have not too much deposits except for some non-specific finding of the, but I think the focal and segmental, those terms also makes me, but then there's also areas of global. Yeah, so I'm really curious to learn, see what actually it is. Yeah, I feel like the kappa lambda could be non-specific, and then the interstitial fibrosis could be secondary to the glomerular process.
Yeah, I will also let you know that there was not a unifying diagnosis. There were several different nephrologists and pathologists who talked about this, and there were just so many different features. There's so many different risk factors, and there was unclear timeline just because he hasn't been seen in 2 years. But ultimately, they end up labeling him with membranous glomerulonephritis. So they were saying that this could likely be a secondary membranous nephropathy that's usually this is secondary to another solid malignancy or hematologic malignancy. So he's actively undergoing an outpatient workup for this at present. Because of the granular deposition of the IgG and C3, he was started on prednisone, 60 milligrams daily, and they're planning for outpatient rituximab for 6 months. There was discussion amongst a lot of different people, was the tubulointerstitial injury just from the NSAIDs and some of the medications that he was using? What role did the hypertension and the diabetic nephropathy, how much of a role was that playing? And so they think that there was an acute injury on top of just a chronic insidious type of injury, but there was no unifying diagnosis that's actually been made. So he's undergoing he's getting a PSA check. He's going to get all of his colonoscopy and all his age-appropriate cancer screenings just to see if there's any solid malignancy that's there. He doesn't have any family history of lymphoma, and his LDH was normal. The peripheral flow cytometry, all those things were normal. He didn't have any lymphadenopathy. But with the steroids and the Rituxan, his creatinine has now come back down to 2.2. And so I think that he's going to, level out around the CKD3B stage, but ultimately some time will tell. So that slight monoclonal spike that he had and the kappa lambda ratio, they were rechecked in the outpatient setting and they both resolved. So they likely was in the setting of just his severe AKI. His creatinine peaked at 3.9, and so now he's back down to 2.2. So ultimately his story is still unfolding, but I thought this was a really, really great case just because he had all the risk factors for all of the just age appropriate things like hypertension and diabetes. He was taking NSAIDs, he was challenging in the setting. So it was just really good to go through the thought experiment of going through the most common things. And then we got into the areas of esoteria. So we had to think about, all the very atypical things that could present this way. And so he definitely had a lot of features of a lot of different diseases, but it was very interesting for our team to go through and just hear the thought process from different people who had expertise in this area. So that's all I have.
What was the degree on biopsy of the tubular interstitial fibrosis? Did they say? Like usually as they'll give you like 25%, 50%, they'll give a percentage of the degree of that.
I have to go pull it up, but I don't have it with me,
That's
and I
okay.
don't remember off the top of my head.
Because especially with global glomerulosclerosis, foot process effacement has also been described with membranous, although it's primarily ascribed to FSGS, but it has been described on seeing histologically with membranous. Any type of nephrotic syndrome, and we talked about this last week a little bit, AKI with nephrotic syndrome can cause ATN because especially when you have a loss of protein, you can get decreased effective arterial blood volume. And that's why just the nephrotic syndrome itself can also be a cause of AKI and ATN. Certainly, again, as you pointed out, he has some tubular interstitial findings, which is not uncommon with nephrotic syndrome and glomerular disease, just because of also the increased work of the kidneys processing the excess protein. So that in of itself, you can often see tubular interstitial process with glomerular disease as well. But this was a fascinating case, and thank you so much. Secondary, the secondary membranous aspect, I still wonder about the NSAID component. I don't know if they talked about that a little bit. Certainly, again, paraneoplastic and then working up other causes of secondary membranous. He doesn't have any features of lupus. There's no immune complex deposition of that. There's no history of any syphilis or anything like that at least he was aware of. And again, they ran hepatitis B and hepatitis C, which was negative, from what I understand. So yeah, age-related cancer screening from solid organ tumoral lymphoma would be part of your differential and how you would work up secondary membranous. Jerome, great case. Thank you so much.
Yeah, thank you so much for the discussion. I really
Yeah, thank you
enjoyed it.
so much, Jerome. I'm so blown away. So much rich differential diagnosis. Learned so much here and from Rich as well. Thank you so much. And thank you so much, Julia, for scribing. And then I think we'll give the mic to Sausan.
Great case, Jerome, and very rich discussion, Mengyu and Dr. Rich. So, starting with the teaching points, how to approach flank pain and acute kidney injury. So, starting with the buckets of acute kidney injury, thinking about pre-renal, intrinsic, and post-renal causes. And another thing not to miss is to think about extra-renal causes that can present with flank pain and acute kidney injury, for example, abdominal aortic aneurysm. And it is also important to ask about any history of trauma, because there's a possibility of subcapsular hematoma that could be the cause of his presentation. And then moving to the history, so the patient had a past medical history of gout. How can we link gout to kidney disease? There are two possible conditions, for example, acute uric acid nephrolithiasis or chronic gouty nephropathy. And then we learned the importance of doing a medication review from Dr. Rich about like how the possibility of like drug interactions like Lipitor and I forgot. Okay. So one thing is it was a great reminder about the possibility of Tylenol causing papillary necrosis, because usually I associate Tylenol with only like liver conditions and diseases, but here it was a great reminder to also think about Tylenol in kidney diseases. And then moving to the physical exam, it can help us prioritize which organ. For example, here with having the periorbital edema, this hints toward hypoalbuminemia. With the bilateral pitting edema and no evidence of heart disease, this made us prioritize the kidney as well. And it is also important to keep in mind the association between obesity and focal segmental glomerular sclerosis. And moving to the labs, there are two ways for quantifying protein in the urine. Number one is the 24-hour urine collection, and then the protein creatinine ratio. And for the protein creatinine ratio to be reliable, we have to keep in mind that the patient has to fit in the Bell's curve. And things that can make it unreliable, for example, having low muscle mass, or the patient is muscular, or if the patient is having a high BMI. And also how imaging can help us make progress is through like looking if there are any chronic kidney changes. The renal ultrasound can help us know like the time course of the disease. And yeah, that was a great session. Thank you all.
Thank you, Salsa. That's amazing summary. I loved your teaching and organization. Also, thank you, Julia, for such wonderful scribing. And thank you, Jerome, again, for bringing up this wonderful case. And thank you, Rich, for co-discussing. It was really fun and learned so much. Thank you, everyone, for your comments in the chat.